Good evening, everyone. Thank you for joining us for our TIF Talk this evening. My name is Wendy Profit. I am in market development with Endogastric Solutions. Joining me this evening is my partner, Karen Girth. Karen, thanks for being here. We're super excited to introduce you to our special guest this evening, Dr. Ketan. I just asked you about it. I'm so sorry. Ketan Shah. He is a fellowship trained gastroenterologist and is board certified in gastroenterology, internal medicine, and pediatrics. He has expertise in treating the entire spectrum of gastrointestinal conditions, including high quality colon cancer screening and prevention, advanced endoscopy and colonoscopy techniques, ERCP, gastroesophageal reflux disease, eosinophilic esophagitis, H. pylori, gastritis, motility disorders, liver disease, pancreatic and bile duct conditions, celiac disease, irritable bowel syndrome, inflammatory bowel disease. Dr. Shah is a community leader in the most up-to-date technology in gastroenterology procedures and is the first community gastroenterologist in Orange County, California to perform the TIF procedure. Welcome, Dr. Shah. Thanks for being with us tonight.
Thank you so much for having me, Wendy and Karen, and thank you for everyone for joining us this evening. It's my pleasure to share about a topic that I feel very passionate about, and we're able to make a huge difference in patients' quality of life.
And it's our pleasure to have you. Thanks again. Well, everybody, if you will, in the audience, go ahead and submit your questions tonight for Dr. Shah in the comments section. We'll go ahead and jump right in. Dr. Shah, if you wouldn't mind, let's go ahead and talk about GERD. What is it and what do patients suffer from?
Thank you. So GERD, it stands for gastroesophageal reflux disease, and it happens when the acid that's in our stomach and normally lives in our stomach to help us digest our food, to help us protect us from infections, to help us absorb our vitamins and minerals. The acid abnormally travels up the esophagus and bypasses the valve that's supposed to protect the esophagus. And I'll share my screen right now to show a video of this. Let me know if you guys can see my video.
I can.
Great. So like we said, there is a valve between the esophagus and stomach that's supposed to protect acid and other stomach contents from going up into the esophagus. But when that valve does not work properly, then acid and other stomach contents are then allowed to go up into the esophagus. This valve, as we can see here, as well as on this diagram, actually consists of two valves that comprise that barrier that protects the esophagus from acid. That barrier consists of the two valves, which specifically include the LES, or the lower esophageal sphincter, or the sphincter muscle between the esophagus and stomach, as well as the diaphragm, which is another valve that's often forgotten about. But both of these valves protect us against acid from going up into the esophagus. And as gastroesophageal reflux happens, both of these valves are abnormally loose and contribute to acid coming up into the esophagus. So that's what GERD is. People also refer to it as acid reflux or reflux, heartburn, and so forth.
Excellent. Thank you for that. So can you talk a little bit about what symptoms your patients most commonly experience, and also those who, we can talk about kind of, typical reflux versus atypical reflux, the symptoms that are associated with those?
Yeah, symptoms can vary widely, but yes, we do usually classify reflux symptoms as typical versus atypical. Typical symptoms are usually referred to heartburn, which can be described as a burning sensation in the chest area, regurgitation, which is when food or other stomach contents travels up into the throat or mouth, difficulty swallowing, where things feel slow or even stuck to go down past the esophagus. So those are the typical reflux symptoms. Atypical symptoms can consist of a huge variety that include cough, sore throat, shortness of breath, wheezing, burning in the throat, globus sensation or foreign body sensation, And there's just a huge variety of symptoms that could be attributable to acid reflux, aside from the normal heartburn and regurgitation.
Gotcha. Thank you very much. Can you talk a little bit about LPR? I know it's in the spring and the fall, we seem to have a lot more conversations about the silent reflux, if you will, because of allergies, I guess. Can you talk a little bit about that?
Great question. So LPR stands for laryngopharyngeal reflux. And as the name suggests, it's when acid reflux affects the structures in the throat, resulting in symptoms like what I just mentioned, such as cough, shortness of breath, wheezing, sore throat, sinus problems, and so forth. Experts actually have not yet come to a consensus on why this occurs, but there are a few theories. One is that acid just simply comes up higher into the esophagus and directly affects the structures. But other theories include the vapors of acid actually affecting the structures rather than acid directly coming up into the throat. Or another theory includes the acid affecting the vagus nerve in the esophagus, and the vagus nerve actually supplies all of these structures, and the irritation of that nerve can potentially cause those symptoms. Nonetheless, people can get throat symptoms and other atypical or LPR symptoms from acid reflux. And one thing that I've learned in my training was that a single exposure to acid in the throat can result in symptoms lasting for weeks. So, and we may talk about this later on about what testing we do for reflux, and one of those tests is a pH study. And sometimes people can have normal pH studies and yet they can still have LPR because, again, a single exposure to acid in the throat can result in symptoms lasting for weeks. So it's a very tough set of symptoms and conditions to treat. But fortunately, our newer therapies do also treat LPR very, very well.
Interesting. Wow. I don't think I knew about, just that one-time exposure, potentially lasting quite so long. So thank you for that. I'm sure our viewers are a little surprised by that as well. So can you talk about, how your patients tell you they've attempted to manage their systems? What are your recommendations for managing GERD?
Absolutely. I'll share my screen again. So these are some lifestyle modifications that most people, by the time they end up coming to me, they've heard it all, they've tried it all, but sure. And the progression of therapies that we recommend do start off with lifestyle, followed by medications. Then we start talking about procedures and surgeries. But certainly lifestyle modifications that are high yield include, number one, absolutely losing weight in those who are overweight or obese. That's the number one most effective lifestyle treatment. But also quitting smoking, eating smaller but more frequent meals. Like we talked about, GERD is a mechanical problem that's caused by a loose valve. So if we don't overwhelm that valve with an overfull stomach, then theoretically we should allow food to stay in the stomach where it belongs. Similarly, staying upright and avoiding lying down within 2 to 3 hours after eating, or despite that, if there are symptoms still at night, then elevating the head of the bed, as opposed to just sleeping propped up on multiple pillows, actually elevating the bed itself, or sleeping on a wedge pillow, which I've tried myself and is very effective. Foods that tend to trigger people's heartburn sometimes include things like chocolate, peppermint, caffeine, alcohol, all the good stuff, of course. But those foods really just transiently cause a relaxation of that sphincter muscle. And there's been less of an emphasis on avoidance of all of those foods because that has just not been found to be as effective as some of the other mechanical types of interventions as I mentioned. Then we come to medications. There are a few types of medications, including over-the-counter antacids, such as Tums, Rolaids, Maalox, Mylanta. And all those do is just neutralize acid. H2 blockers or histamine 2 blockers include things like Zantac, Pepcid, ranitidine, famotidine, Axid, cimetidine. And those block the histamine receptor on the stomach cells. It's one of the multiple signals that the stomach cells receive telling them to make acid. So again, it blocks one of the multiple receptors telling the cells to make acid. And then the proton pump inhibitors, which we've all heard about, which include things like omeprazole, Prilosec, Nexium, Prevacid, Protonix, Pantoprazole, Dexilant, and there are a number of others. And those block the proton pumps, which are the microscopic pumps that are in the stomach cells that actually pump out acid into the stomach lumen. And so those work further down the line in the production of acid, and hence they're the most effective at blocking acid. But again, we are talking about either neutralizing acid or suppressing acid secretion. But as I mentioned, we all need acid. Acid is normal. Acid is important for us to digest our foods, absorb our vitamins and minerals, protect ourselves against infections. And treating acid reflux by suppressing acid puts a Band-Aid. It gives us a chemical to mechanical problem. And so the real fix to a mechanical problem is a mechanical fix. And I do feel strongly about this. Not to say that proton pump inhibitors and other medications are not effective. They can be very effective, but there's a lot of controversy that everyone has by now heard about regarding possible side effects, long-term side effects with proton pump inhibitors. The jury is still out about that. There are lots of studies both showing, yes, there may be some long-term side effects. No, there may not be long-term side effects. So it is controversial. My opinion, are there likely side effects from proton pump inhibitors taken long-term? Yes. How important or dangerous are those long-term side effects? It's hard to know. It's probably not dangerous, and I have lots of patients who are on PPIs for years and years, so I'm not against it, but I think it's a chemical fix to a mechanical problem.
Gotcha. So in other words, if I'm understanding correctly, they won't fix a dysfunctional valve that contributes to GERD.
You're exactly right, Wendy. And when we treat patients with medications, do they still reflux? I get that question all the time. Am I still refluxing? The answer is absolutely. But the reflux changes from acid reflux to non-acid reflux. And that is a thing. Non-acid reflux is a thing. So the patient, to give you an example, I frequently get patients who say, okay, I've had heartburn for many years. I've had regurgitation for many years. I've been taking PPIs for many years. And the PPIs work great for my heartburn. I no longer feel burning in my chest, but why do I still feel stuff coming up? And the answer is, you're still refluxing. You're just not refluxing acid anymore. You're refluxing non-acid. You're refluxing stuff that's not acidic anymore, but it's still coming up. And mechanical fix to fix the valve is the perfect solution for someone who has what we call regurgitation predominant GERD, which is when people feel stuff coming up, and medicines are not going to change the fact that stuff is coming up.
Thank you. So if GERD is not managed by one of the things that you've discussed so far, or by what we're going to get to in a few minutes, what can that lead to?
Questions. So I get this question all the time. I'll share my screen. You see a gray box on the top right, but I moved it out of the way if that helps. So great. I get this question all the time. Why does it matter that I have GERD? And the answer is actually two reasons. One is it makes you feel bad. So we want one of our primary goals is to make patients feel better and to treat their symptoms so that they don't feel bad and they're able to function and have a good quality of life. But the other is something that we also care deeply about, which is the long-term consequences of GERD, which can include esophagitis or inflammation of the esophagus or erosions in the esophagus that we visibly can see on endoscopy. And if esophagitis goes untreated for long periods of time, that can lead to serious conditions. That includes things like ulcers, hemorrhage, or major bleeding. scar formation from that chronic inflammation, which we call strictures or narrowings in the esophagus where food can get stuck. And that can be life-threatening because patients can choke on their own saliva if food gets stuck, and they can die from that instantly. And then esophageal cancer is definitely a big thing on most people's minds. Precancerous change from reflux is called Barrett's. That's present actually in up to 25% of people with reflux. So that's not uncommon at all. And then obviously that's a precursor to esophageal cancer, which is the most, let's see. So esophageal cancer is the most rapidly rising cancer in incidence in this country compared with all other cancers. It is an epidemic. And we feel that this epidemic is due to the epidemic of GERD. And we see here on the right-hand side of the screen that the incidence and the mortality from esophageal cancer is rapidly rising still to this date. And it is one of the most aggressive and serious and lethal types of cancer. So it is not one that we want to. So those are the consequences of reflux. The bad consequences are rare. So I'm not here to scare people. The bad consequences are rare, but I do see them. I do see them all the time.
All right, thank you. So can you talk a little bit about the tests that are used to diagnose GERD when a patient comes in and sees you?
Great question. So not every patient needs tests. If a patient comes to me saying, I have heartburn, I have regurgitation, it's worse after I eat, I tried a PPI, I tried a 14-day course of omeprazole, and I felt 80 to 90% better, there's a diagnosis. You have GERD. That being said, some people do need an endoscopy, which we commonly perform. Some people call that an upper GI endoscopy, where we give patients sedation to make them sleepy and comfortable. We usually use like a twilight or what's called conscious sedation, but most people don't remember the procedure. Then we insert a camera down their mouth. It's at the end of a long flexible tube about the size of my little finger. And I examine the esophagus, stomach, first part of the camera, take some pictures, usually some biopsies. It's about a 10-minute procedure, outpatient. Patients go home the same day and are able to function and drive the following day. So that's a pretty commonly performed procedure, is an endoscopy. Sometimes even before that, we'll do what's called an esophagram, which is like an X-ray or a roadmap of the esophagus where a patient will swallow some contrast and down with X-ray. Oftentimes, if we're starting to talk about anti-reflux surgery or procedures, or if we're unclear about whether someone has acid reflux, especially if they have atypical symptoms or LPR symptoms, we will often add on what's called a pH study to the endoscopy. The brand that most people use is called a Bravo, the brand of that type of study. But what it is, it's a probe, a temporary probe that we attach during an endoscopy in the esophagus. It attaches by suction, interestingly, falls off on its own after several days and passes through the stool. But it's a wireless that wirelessly communicates with the monitor that one wears for usually 48 hours around their neck. They back to the doctor's office. The probe doesn't need to be removed. It just passes through the stools on its own. That monitor and that pH test will tell us two things. Number one, yes or no, is a patient having abnormal during those 48 hours? Number two, there are buttons to press on the monitor for patients to communicate to us when they have symptoms. And we come up with a symptom correlation score or a likelihood of whether their symptoms are temporally correlated with acid reflux events. So those are the usual tests that we do during the workup or investigation for acid reflux.
Excellent, thank you. So we're going to cover a couple more questions and then I'm going to turn it over to Karen. I understand we've had several questions coming in from the audience. So thanks for hanging with us, everybody. We're going to get to those in just a second. While I've kind of got you on a roll, we've talked about our lifestyle modifications, we've talked about medication, we've talked about the testing that can be done just based on symptom presentation. So can you talk a little bit about what occurs after lifestyle medications or excuse me, after lifestyle adjustments, after medications have been tried, breakthrough symptoms, patients still needing a fix, what's next?
Yeah, great question. So I'll go through that try as briefly as I can, but I think that's an extremely important question. So we'll first, we can't talk, I'm sharing my screen right now. So we can't talk about anti-reflux surgeries without talking about the most time-tested surgery that's been performed over 50 years called the Nissen fundoplication, which is when a surgeon laparoscopically takes the top of the stomach and wraps it around the bottom of the esophagus, and it creates a new barrier between the esophagus and stomach, and it is highly effective at controlling reflux. However, this is more of a barrier than a valve, and so patients can not infrequently have some complications from that barrier and can commonly or not uncommonly have side effects, including the ones listed here, such as difficulty swallowing, difficulty with being unable to belch or vomit, having increasing gas, bloating, flatulence, diarrhea. And another procedure that we commonly hear about is called the Lynx procedure, where a surgeon places a ring of magnetic beads around the bottom of the esophagus. And they call that the magnetic sphincter augmentation, where this ring is supposed to expand to allow food to go down and stay closed to prevent acid and other stomach contents from going up. I do have a few concerns about that, in that 10 to 15% of patients still complain of dysphagia or trouble swallowing because the ring doesn't necessarily expand as much as we'd like. It is a foreign body consisting of magnets. There have been reports of erosions, and there is a publicly reported database called the MA database that the FDA reports how often these are removed. And it's surprising that actually a couple hundred a year in this country are removed due to problems. There are restrictions on MRIs that people can get after having the Lynx procedure. And so reasons why people consider anti-reflux surgery to begin with include potentially inadequate symptom control, side effects, either perceived or fear of side effects from PPIs, or other reasons for wanting to just stop anti-reflux medicines. And the TIF procedure, which stands for the transoral incisionless fundoplication, in my opinion, has the best balance between tolerability and effectiveness. And the main reason is because it restores our anatomy almost back to normal. We're recreating a valve rather than a barrier. And over 95% of patients now are able to completely stop their PPIs. But if I can't emphasize one thing enough, it's the rate of long-term side effects. We talked about the rate of long-term side effects with older types of surgeries being up to 50% actually. And with the newer types of surgeries like the TIF procedure, rate of long-term side effects is less than 1%. So during this procedure, we go down through the mouth, and using this device called the esophagus device, and under the guidance of the camera, we are literally reconstructing the valve as close to normal as we possibly can that technology is available for today. And we do this several times, where we retract stomach from the tissue from the top of the stomach, and we wrap it, and we place these non-absorbable sutures to fasten and force the work. And we, in a 270-degree fashion, we reconstruct the valve to create something as close to normal as we possibly can. And let's see if this will let me. I wanted to mention that this procedure often is associated, or we perform this procedure with, in conjunction with something called a hiatal hernia repair. And my PowerPoint is back up, so I'm going to share my screen again.
Okay.
Yeah,
this is something that I think a lot of folks have questions about, as we see, in forums on social media. People have a lot of questions about hiatal hernias and what happens if they have one. Is the TIF procedure still something that's an option for them?
Perfect. So again, my diagrams are not working, so I'll just describe it with words. That again, there are two valves that comprise the barrier between the esophagus and the stomach. One of those valves is the diaphragm pinching the lower part of the esophagus, and both of these valves need to be fixed. If we just do a TIF procedure or just do a Nissen fundoplication or whatever, it's not going to fix or address the other valve, which is the diaphragm pinching the lower part of the esophagus. When that diaphragm becomes looser, then the stomach is able to herniate or travel above the diaphragm into the chest cavity, and that also significantly contributes to reflux. So a vast majority of patients do also need what's called a laparoscopic hiatal hernia repair, which is when a surgeon makes 4 to 5 small half-inch incisions in the abdomen. Usually takes them about 45 minutes to an hour, where the surgeon then fixes that hiatal hernia by bringing the stomach back down below the diaphragm where it belongs, and then reinforcing the diaphragm, the opening in the diaphragm, back to the size that it's supposed to be, just by placing a few small sutures in the diaphragm, and that really is it. So we call that the TIF procedure, or the concomitant transoral incisionless fundoplication, where again, there are 2 components of the procedure. One is done through the mouth to fix the lower esophageal sphincter muscle between the esophagus and stomach, and the other is the laparoscopic hiatal hernia repair, where a general surgeon usually goes in through the abdomen, 4 to 5 small half-inch incisions, and laparoscopically fixes hiatal hernia. And the combination of these 2 procedures has tremendous results in really curing people of their acid reflux and normalizing acid exposure in the esophagus, and allowing them to eat normally and eat what they want to eat. And most importantly, over 95% of patients are able to completely stop their PPIs, and less than 1% of patients have long-term side effects from this, which is tremendous. We don't hear those numbers very frequently in the world of surgery and procedures.
Excellent. Thank you for sharing that. Karen, I would love to, I'm sorry you've been waiting very patiently, and I appreciate that. This has just been great information for the audience. Do you have a couple of questions you want to toss out there for Dr. Shah?
I do. Thank you, Wendy. So we have a question from Christopher. He's wondering, how long is too long to stay on PPIs before seeking treatment?
That's a great question, and I wish I had a good answer to that, which there isn't a good answer. I mean, if someone requires PPIs for a long period of time, and we usually consider that years, whether that's 1 year, 5 years, or 10 years, it's hard to know what the right answer to that. Do I have patients on PPIs for 10 plus years? Yeah, absolutely. All gastroenterologists do. I can mention that in 2018, the first ever randomized placebo-controlled trial was performed comparing PPIs versus placebo, and comparing the rate of side effects among those 2 sets of patients who are taking PPIs versus placebo. Fortunately, it did show that PPIs generally are pretty safe, but the limitation to that study was that patients were followed for an average of 3 years. And so the answer is, that's, at least in that randomized trial of about 18,000 patients, taking PPIs for 3 years is probably pretty safe. Taking PPIs for longer than that, we don't know.
Thank you for that. We have a question. I don't even know if I've seen this question before, so I can't wait to hear the answer. What's the relationship between gallbladder removal and acid reflux?
That's a great question. And actually, surprisingly, I'm asked that question all the time. And one of my other area of interest is the gallbladder and the bile duct. So I'm actually happy to answer that. And so we talked about acid reflux. We've talked about non-acid reflux. There's also bile acid reflux, which I wasn't going to mention because it's not as common, but it is probably more common than we think. And when patients have their gallbladder removed, or even in some patients who still have their gallbladder, for some reason in those patients' anatomy, they drew the lucky straw of the bile going up into the stomach. And we call that bile reflux into the stomach, causing bile gastritis. But when bile goes up into the stomach, then it can also reflux up into the esophagus, just like anything else in the stomach, whether it's acid or non-acid. And it's the same problem. Stuff that doesn't belong in the esophagus is now going up into the esophagus, and this is also acidic. Bile is acidic. And so fixing the valve, again, protects the esophagus from acid, from non-acid, or from bile acid.
Thank you for that. And then I have one more question. The question is, can GERD cause dental erosion?
Great question. The answer is absolutely. So if you look at dental textbooks, they actually grade the degree of dental erosions caused by acid reflux. And I do get referrals from dentists who have diagnosed dental erosions from acid reflux to treat the patient's acid reflux. And sometimes that's the first sign or first and only sign that a patient has of acid reflux is dental decay and dental erosions. And so that is a real thing. If you look up a dentist's textbook, then we see acid reflux manifestations in there.
That's great to know, and I'm glad that you have a dentist that's able to refer patients to you.
Absolutely.
Oh, and I bet you there's at least a few members of the audience right now jumping on Google. Dental textbooks, dental erosion, acid reflux.
It is a real thing.
All right, very good. So can you talk a little bit, Dr. Shah, about life after TIF? What does the recovery look like? What do your patients say about their lives after this procedure?
Great question. So I'll answer that question in two parts, both how patients feel right after surgery and then how patients feel in the long term. So this is a surgery, I'm not going to lie. And so patients do usually, like I said, get incisions, although again, small half-inch incisions in the abdomen. And so patients do usually have some incisional type of pain in their abdomen, usually managed very, very well with oral pain medications. It's very rare for patients to need pain medications for longer than 3 to 5 days. So they can expect to feel like they would with any sort of abdominal surgery for about 3 to 5 days. And then for the next few weeks, patients feel much better. They feel almost back to normal. Sometimes they can feel some swelling sensation in the lower part of the esophagus. Not surprisingly, we just worked in that area and reconstructed that area. So for that reason, we actually do recommend patients to be on a liquid-only diet for 2 weeks and then a soft-only diet for another 4 weeks. Again, not because patients feel bad and can't tolerate those things, but just to allow that newly reconstructed bowel to fuse and to heal. And so after that 6-week mark, patients can pretty much go back to their normal diet and activities. And then at about the 3-month mark is when patients say they feel back to their new baseline. With that diet modification alone for 6 weeks, patients are usually happy to report about a 15 to 20 pound weight loss. Although I have had a few skinny refluxers. I'm a skinny refluxer myself, so I can say that. And I have in patients who have a normal weight or who are underweight, they actually concerned that they're going to further lose weight after this. And I reassure them that, you're not going to necessarily lose weight, especially if you just stay on top of your caloric intake. But yes, most reflux patients are overweight or obese just by statistics. Those patients are happy to see a 15 to 20 pound weight loss during that immediate recovery period. And then what I hear from patients, which is really interesting, they're very happy. They say overwhelmingly their heartburn is gone. Their regurgitation is gone. They're off of their PPI. But interestingly, what I hear is that I just feel like I can't eat as much. Is there a problem? And I say, no. That is how much your stomach is designed to handle. But because we have had and we've been living with this loose bowel for so long, and we've been refluxing whatever we overeat, this procedure now makes it less likely that someone's going to be able to or want to overeat, because now they have a newly properly functioning bowel.
Excellent. Thank you very much. Karen, I'll ask, do we have any other questions that have been submitted that haven't been covered in the discussion before we close out?
Most of them have been pertaining to recovery and exercise. When can they return to normal exercising, like running?
Great question. So during the first week, once people feel better from their incisional pain, they can go back to walking and doing light housework, driving. That's within the first 3 to 5 days. And then there is actually an activity restriction that we recommend. Again, not because patients can't tolerate it, but it's to allow the newly reconstructed valve to fuse and to heal. And so we do ask patients to not lift anything over 5 pounds for about 2 weeks. We ask patients not to lift anything over 10 pounds for another 4 weeks. So really at that 6-week mark is when patients can gradually go back to their normal activity, because by that point the valve has been fused and healed. So there's about a 6-week recovery period. Again, not to scare people into thinking they're going to feel bad for 6 weeks, but I like to emphasize that recovery is to allow the newly reconstructed valve to fuse and to heal.
Excellent. Thank you so much. Well, we're getting ready to wrap up. What I love to ask our guests, and I will ask the same of you, is, do you have any parting thoughts that you'd like to share with anybody who might be on the fence, who's starting to finally get in touch with the fact that maybe something is not as normal as they thought it was, they're toying with coming in? What can you share with them?
I would share with them, just get seen, make an appointment. At the very least, patients who have had reflux for a long time, most of those patients should be screened for Barrett's esophagus, because that can be present in up to 25% of patients with long-term acid reflux. And so at the very least, they should get seen. They should get seen, get screened, potentially get screened for Barrett's esophagus if that's indicated. And the other message is that anti-reflux surgery and procedures are not scary anymore. And even a lot of physicians and gastroenterologists still don't realize that. And I want to put that message out there that as a gastroenterologist myself, 10 years ago, I was extremely hesitant to refer patients for anti-reflux surgery because the rate of long-term side effects was so high with the older types of surgeries. 50% of patients potentially reporting problems with their swallowing. It's like, why subject someone to that if their symptoms are just not debilitating enough? But now I am treating patients' reflux in a much earlier stage of the severity of their reflux. And I encourage people out there, whether it's patients, physicians, even gastroenterologists, to start thinking about anti-reflux surgery and procedures much earlier, because we have the technology now to treat it in a safe and effective manner with a very, very low side effect rate, and potentially even lowering the rate of long-term complications of acid reflux, including esophageal cancer, strictures or narrowings, bleeding, ulcers, esophagitis, and also potentially lowering the risk that someone can have from taking long-term PPIs. So there are risks to everything, but I think with our current state of technology, we are able to treat patients' acid reflux in an extremely safe and effective manner.
Well, thank you, Dr. Shah, so much for everything that you've provided tonight. The information has been phenomenal. If you are in the Orange County or Southern California area and are looking to seek treatment for potential symptoms, look Dr. Shah up. Also, if you are not in that particular area and would like to find a TIF specialist, you can go to our physician locator at gerdhelp.com. Simply type in your zip code and you'll be able to see the TIF specialists in your area. Also, if you are looking for a tool to help you identify and manage your GERD, you can go ahead and look for on gerdhelp.com our mobile app. It will help you record symptoms. It will help you look for articles, videos, much like what we've seen this evening with Dr. Shah. There are physician interviews, and you can take this information to your doctor along with lists of questions to help you have the most productive visit that you can with your doctor. And Dr. Shah, I would assume that the doctors will appreciate that too. The more specific information patients can bring in, hopefully that makes your pathway for treatment decisions a little easier as well.
I completely agree.
Perfect. Thank you. All right. Well, everybody, thank you again. Dr. Shah, if you'll hang with us for just a minute more, we'll say good night to everyone. Thanks for tuning in. You'll see us next Tuesday, and we'll look forward to it. Thank you so much for joining us. Good night.
Thank you so much for having me and for tuning in.